The authors have no financial interest in the products shown in this video. This is a story of a 25-year-old male who was seen by us earlier. He was an emmetrope and had disc coloboma in the right eye with normal fovea and 6x6 vision detected on a routine eye examination. 3 years later, he presented to us with sudden onset defective vision in the right eye. The visual acuity was 636 now in this eye, and he had a large pocket of subretinal fluid at the macula and nasal retinal detachment. This patient with disc coloboma and retinal detachment underwent pars plana vitrectomy with a 25-gauge system. After a core vitrectomy, PVD induction was attempted with suction. IVTA was used to highlight the posterior hyaloid and aid the PVD induction. Vitrectomy was then completed. A good peripheral vitrectomy was also attempted. Brilliant blue dye was used to stain the internal limiting membrane and delineate the premacular membranes clearly. The premacular membranes were peeled with a forceps. Endodiathermy was used to create a nasal retinotomy to drain the subretinal fluid. Fluid air exchange was done with passive aspiration of the subretinal fluid through the nasal retinotomy. Laser photocoagulation was done to the nasal retinotomy. Laser photocoagulation was also done to the nasal border of the optic disc coloboma. This was followed by silicone oil injection. Postoperatively, the macula was attached. There was a small pocket of fluid superior and inferior to the disc. OCT showed settled nasal detachment and near normal foveal contour. 4 weeks later, he presented with further drop of vision. OCT now revealed a large fluid pocket at the fovea and recurrence of nasal retinal detachment. He underwent a second surgery now. Attempt to drain the nasal subretinal fluid with active suction was attempted under the silicone oil, but to no avail. Silicone oil removal was done. Repeated attempts to remove the nasal subretinal fluid with active suction through a retinotomy was attempted, but it could not be done. That is when I realized that it could be subretinal silicone oil and not subretinal fluid. As subretinal silicone oil could not be removed through a small retinotomy, the retinotomy was enlarged. A retinectomy was done. The trapped subretinal oil was finally removed and fluid air exchange done. Laser photocoagulation to the nasal retinectomy was done. This was followed by additional laser to the nasal disc margin. After ensuring that the disc surface was relatively dry, tissel fibrin glue was applied. The first drop of glue component, containing a mixture of sealant protein concentrate and synthetic A-proteinin, was injected, followed by the second drop of glue component containing human thrombin and calcium chloride. Note the instant white fibrin coagulum at the disc. This is followed by silicone oil injection. The sclerotomies were closed with sutures. This is the postoperative OCT showing the fibrin coagulum within the optic disc coloboma area and a superior trapped fluid above the disc. 2 weeks later, repeat OCT of the disc revealed disappearance of the fibrin coagulum at the disc coloboma. OCT of the macula revealed attached macula with no subretinal fluid. The superior pocket of subretinal fluid is probably residual silicone oil trapped. This is the fundus photograph at 6 months follow-up. The macula is attached with superior pocket of subretinal fluid still seen. This patient maintains a visual acuity of 636. OCT of the macula revealed attached macula. To our knowledge, this is the first case in literature where fibrin glue was used to aid closing disc coloboma associated with retinal detachment. There is, however, a report of cyanoacrylate glue being used in a case of recurrent retinochoroidal coloboma with retinal detachment. This case also confirms the safety of fibrin glue when used intraocularly, as there was no postoperative inflammation, as also supported by earlier animal studies. This video also demonstrates how subretinal silicone oil may be mistaken for subretinal fluid and needs a modified approach for its removal.